Hi, this is Neil Hansen. I'm going to take you through the aorta CT and how to look at an aorta protocol CT scan. So initially you'll see there are several series up. Every acute aorta starts with a non-contrast series. So that's usually the first thing the techs do is scan a non-contrast series, and the purpose of that is to look for an intramural hematoma. So as we scroll through here, you can see that the ascending aorta is dilated, and if I zoom in, you can really tell that there's a crescentic area of higher attenuation within the ascending aorta. That's an acute intramural hematoma. That's the whole reason that all of these studies start off with a non-contrast scan. If you compare that with the arterial phase study, which is what most people think of when they think of an arteriogram phase CT scan, it can be much harder to diagnose that high attenuation crescent. And so it's always important for the first thing you do when you're approaching one of these studies is to bring up the non-contrast, scroll through, look for that high attenuation crescent. The next phase that's obtained as part of a aortic CT is the arterial phase, and you can see it here where the contrast bolus is predominantly within the aortic lumen. To achieve this, we do something called a smart prep. So if you look on the right hand of the screen, the technologists put a region of interest in the ascending aorta. They begin injecting contrast, and then when a threshold is met, which is what you see here they put the region of interest in the descending aorta. Once they reach a certain Hounsfield unit threshold, they trigger the scan to be done. So that way they get optimal bolus timing for the vessel of interest, in this case the aorta. When I read an aorta CT, I always start at the base. You start at the aortic root, and then you go all the way through the bifurcation. To look at the aorta valve plane, I like to do multiplanar reformatted images. So if you click this button in the top left aspect of your McKesson screen, and you go to 3D, you can do a MIP, you can do a color image, or what I like to do is use one of the presets and do a 3D MPR layout. There's something called the double oblique plane, which is used to evaluate things like the aortic valve. So if we zoom in here on the aortic valve, and you bring your crosshairs to the aortic valve plane, then you can ensure that it's trileaflet. So double oblique. So the first oblique is done in the axial plane, and the second oblique is done in the sagittal plane. And then if you look down at the bottom left image, when you scroll through, you can be confident that it is a trileaflet valve. One of the differentials for an ascending thoracic aortic aneurysm is a bicuspid valve, so it's always important to make sure that they have a trileaflet valve. In this case, the ascending aorta was quite dilated, and that wall weakness led to the intramural hematoma. But after you look at the valve plane, you scroll up. I always pay attention to both the right and left coronary arteries to make sure that they're coming off and well opacified. So you can see here's the left coronary artery, and then more anteriorly here's the right coronary artery, and then it's just a checklist. You scroll through and look at the ascending aorta, the arch. Always look at all three great vessels coming off of the arch. Descending aorta, down into the abdomen, where you always identify the celiac axis, superior mesenteric artery, bilateral renal arteries, and then finally the inferior mesenteric artery, which you can see is very diminutive in this patient. Now if I switched over to a dissection, it's important when you read an aorta CT for a dissection that you describe exactly where it goes. There are two types of dissections. There's a Stanford classification A and a Stanford classification B. It's very important to distinguish these because surgical intervention is required for Stanford A aneurysms and dissections versus just medical management for Stanford B. So if any part of the ascending aorta is involved, which in this case it obviously is, it's a Stanford A and requires kind of emergent surgical management. But I'm just going to take you through this focal dissection to describe how you would approach reporting this in a CT report. So again, you look at the aortic valve, then you go to the sinuses of Valsalva level. In this case, that's where the aortic dissection starts, so it's type A because it involves the ascending aorta. Always check your coronary arteries. In this case, the dissection comes right up to the right coronary artery here. Occasionally the dissection can go into the coronary arteries and cause a myocardial infarction. Here's the left coronary artery, and that looks well opacified. But the aortic dissection originates in the ascending aorta. We have both the true lumen, which you can see here, and the false lumen, which is only partially opacified. So we'll follow the dissection up into the arch. The dissections frequently go into the great vessels. Here you can see it going into the brachiocephalic artery on the right, and up to the bifurcation into the carotid and right subclavian artery. As we follow that dissection down, it goes into the descending aorta. And it's important to describe the extent as well as the degree of opacification of both the true lumen, which you can see here, and the false lumen here. There's something called the bird's beak sign. The bird's beak sign occur at an area of an interface between the true and the false lumen. Frequently it will form a bird's beak looking interface, and that's a sign that this lumen here is the true lumen and this is the false. As is the case here, I find most commonly the false lumen tends to be a little bit larger than the true lumen. Here we come up on the celiac axis. It's important to describe which branch vessels the dissection goes into, as well as which branch vessels arise off of the true lumen and the false lumen. So here the celiac axis comes off of the true lumen, SMA comes off the true lumen, right renal artery comes off the true lumen. If you look here, this left renal artery comes off the false lumen. If I window it very aggressively, you can tell that the false lumen is preferentially getting less flow. This left kidney is not opacified quite to the level of the right kidney, just a slightly delayed nephrogram related to having to go through that false lumen, and there's a decreased velocity frequently within the false lumen. In this case, the dissection goes all the way down to the aortic bifurcation into the iliac arteries, and so it's just important to comment on every single artery specifically in these dissection cases to know, let the referring clinician know exactly where the dissection goes to, as well as potentially look for complications such as end organ ischemia or delayed nephrograms